Well, welcome to our webinar this evening on Baroreflex Activation Therapy, a novel approach to heart failure with reduced ejection fraction patients. I am Gurusher Panjrath, advanced heart failure transplant cardiologist from George Washington University in Washington, D.C. I'm professor of medicine and director of the Heart Failure MCS program. We have a fantastic faculty joining us tonight. I have Dr. John Jeffries, who is a J. Michael Sullivan Distinguished Chair in Cardiology. He's a professor and chief of adult cardiovascular medicine and a professor of pediatrics as well at the University of Tennessee Methodist Hospital System in Memphis, Tennessee. We also are joined by Dr. Christina Economidis from the PIH Good Sam system in Los Angeles. She's an interventional cardiologist and is very well experienced in Baroreflex activation therapy and will be sharing her experience with us as well. Couple of housekeeping notes. Tonight's webinar will be recorded. Webinar will include 3 presentations followed by a question and answer session. So we encourage participants to enter their questions into the chat box so that we can address those in the question and answer session. With this, I'm going to go ahead with our first presentation, which is by myself on Baroreflex as a therapeutic target in heart failure with reduced ejection fraction. We all are well aware of all the recent developments in pharmacotherapy for heart failure management and the associated improvements in outcomes related to these therapies. Current options in heart failure management include 4 pillars, which are ARNIs, beta blockers, MRAs, and SGLT2 inhibitors, which form the foundation of heart failure therapy. There are obviously many more agents as well, which can be useful. But despite all these advances and improvement in outcomes in clinical trials, in real life experience, we know that based on estimates, up to 30 to 40% of patients are not on optimal GDMT or guideline-directed medical therapy. This could be due to a multitude of causes. Some patients may be non-adherent due to inability to afford medications, cost, or due to intolerance as well as lack of efficacy in some. If we look at some of the recent clinical trials, we know there is a significant residual risk which remains despite contemporary medical therapy. In fact, when we look at the Emperor-reduced trial, which was recently published, even in the drug arm, patients on contemporary therapies, 19.4 of those had a primary outcome of cardiovascular death and heart failure hospitalization. This residual risk, which is in the shaded area, is even higher in those in the placebo or the control group, which mimics some of the real-life populations and poses as an unmet need, which can be addressed with newer advances in therapies. For those patients who may or may not respond to pharmacological agents and may have other specific indications, there are options besides pharmacotherapy, including device options. Specifically for patients with severe mitral regurgitation, a select few of them may be candidates for transcatheter edge-to-edge repair. Those with atrial fibrillation, some of them may benefit from catheter ablation, and those with a left bundle branch block, an indication for CRT, may benefit from CRT therapy. However, despite all these options available, there's a significant number of them who may not be candidates for these therapies or CRT, and that again poses as an unmet need for new developments for management of their symptoms. In fact, based on estimates, CRT is actually only indicated in 30% of heart failure with reduced ejection fraction patients, with 70% of these HFrEF patients do not have an indication for CRT. Many therapies have been explored over the past decades, including vagal and spinal cord stimulation. However, these therapies did not meet clinical endpoints in the previous clinical studies. Despite this, autonomic modulation was continued to be explored as a therapeutic option, resulting in advent of Baroreflex activation therapy. Let's review the role of autonomic nervous system in cardiovascular hemostasis. These are well-known and well-established functions of the baroreflex. Arterial baroreceptors stretch less as the systolic and pulse pressure diminish. Activation of the cardiac sympathetic reflex causes a reduction in the arterial baroreflex heart failure modulation. In response to drop in cardiac output and blood pressure, arterial baroreceptors unload with immediate activation of the sympathetic and renin-angiotensin pathways and resulting in decreased vagal tone, reflexively to compensate. In this slide, you can see in blue lines, which highlights the main pathway, which is mediated by baroreceptors. Heart failure is a state of autonomic distress, and there's a generalized increase in sympathetic nerve traffic, blunted vagal and parasympathetic heart rate modulation, and impairment of the reflex sympathetic regulation of vascular resistance. The primary mechanism for autonomic modulation is via the baroreflexes, and the autonomic nervous system and the renin-angiotensin aldosterone system are chief creators of hemostasis in the body. When there is a decreased baroreceptor signaling, sympathetic outflow goes up. There's a reduction in parasympathetic outflow and a resultant increase in heart failure symptoms. Let's review some of the previous preclinical evidence of role of baroreflex downregulation in heart failure patients. In this particular study, heart failure patients were shown to have less of a change in systolic blood pressure in response to changes in pressure on carotid baroreceptors compared to normal patients. In this graph, you can see an association in worsening heart failure symptoms as depicted by New York Heart Association class and baroreflex downregulation, or which were assessed by baroreflex sensitivity. As you can see, patients with class 3, class 4 symptoms had a greater degree of baroreflex downregulation compared to those with class 1 and class 2 symptoms. With decrease in baroreflex sensitivity or baroreflex downregulation and loss of control over the heart rate or reduced modulation, there's an association with working survival. And as seen in this particular graph, as there's a strong correlation between patients with reduced baroreflex sensitivity and worse survival. So now we know that baroreflex regulation is downregulated in heart failure. And this downregulation has significant physiological effects, such as increase in sympathetic tone, increase in norepinephrine, filling pressures, and reduction in kidney function. And this results in significant clinical outcomes or consequences, such as increase in biomarkers, such as NT-proBNP, worsening quality of life, increasing heart failure symptoms, reduction in exercise capacity, as well as increased mortality and morbidity associated with that. So with this, I would summarize by saying, despite advances in GDMT for heart failure patients, there's still an important complementary role for devices to improve outcomes in this population. Almost 70% of NYHA class 3 heart failure patients with an ejection fraction of less than 35% are not indicated for CRT. The baroreflex plays a central role, in fact, a pivotal role in regulation of the autonomic nervous system and cardiovascular hemostasis. When the baroreflex is downregulated, the autonomic nervous system becomes unbalanced. There's elevation in sympathetic tone, there's decreased parasympathetic tone, and all this is associated with worsening heart failure symptoms. And finally, and most importantly, the baroreflex is an attractive therapeutic target for heart failure patients